We come to our next talk by Dr. Chandrashekhar Wavikar and the future, the flax with toric. And he is a toric guru for the entire country. I guess, sir, please enlighten us.
Thank you, Dr. Swati, for those kind words. I hope you can see and hear me.
Yes, sir. We can.
Yes, sir. Very well.
So very nice talks up till now. Everybody contributed really well. And now we are going to talk about future of the astigmatism management, that is with femtosecond laser assisted cataract surgery. So flax or femtosecond laser assisted cataract surgery has got many areas in which we can manage the astigmatism. So let us start with incision. Number one is that we have got a complete control over the cyclotorsion, and therefore there is a degree-wise accuracy in the placement of the incision. Then placement with respect to limbus. Once upon a time there was a doubt whether we can put them at the limbus above the beyond the limbus, just inside the limbus. But now we are bang on sure, and the arcus senalis, which used to be a problem, is no more a problem, and therefore we are going to place it exactly just inside the limbus, and that also ensures total very good control over the SI. Consistency of the configuration. Whenever we are taking an incision with a metallic blade, slight movement, even while withdrawing the blade on the right or left hand side, changes the configuration of the incision, and sometimes it can be costly. Remember, our centroid SI is 0.1, but many times, this is an average, many times the astigmatic SI can be as high as 0.75. But with flax, the chances of that are very less, and therefore you are very unlikely to get surprises. Reverse trapezoid. Now, when we are in the incision main port, the maximum side-to-side movement of the phaco needle is at the inner lip. With manual incision, it is not possible to take reverse trapezoid. That means the inner lip is bigger than the outer lip. You can take a trapezoid where the outer lip is bigger than the inner lip, but it does not serve our purpose. Only with flax you can take a reverse trapezoid incision where the inner lip is bigger, and therefore the distortion is less, and therefore the SI does not go awry, especially if you are tackling a hard cut. Then the second point about flax is CCC. Because the CCC is exactly centric and very circular, there is it is ensured that the placement of the lens is accurate, not in the short term, but also in the long term in case the fibrosis takes place. Therefore, any astigmatism induced by shifting or the tilting of the lens is avoided. Then we go to LRI, fantastic lectures on LRI by Dr. Shilpa especially. Placement of arc as per the diameter. Okay, so we are independent of the corneal diameter. It will not have any impact on the amount of astigmatism induced by the LRI, but it still makes a lot of difference because smaller the cord length, less will be the irritation. Degree-wise precision. Now we are using cylinder, we are incorporating posterior corneal astigmatism. So our cylinder is not in the steps of 0.25, but in the steps of 0.1. And therefore your LRI can be 48 degrees to 73 degrees. Such a placement exactly from 40 to 73 is possible on a flax only. It is not possible with LRI, especially along with cyclotorsion. Then I am placing it on the 8 millimeter diameter, which is too far away from the pupil to create any, dysphotopsia. But at the same time, it is not so big that it will cause foreign body sensation or dryness. The pachymetry is OCT based. On every point where the LRI is going, you are getting a pachymetry, and therefore your depth is precise, which is why you are getting a very good effect of the LRI in flax. Then end-to-end uniform depth. Whenever we are taking manual LRI, the starting and the end of the LRI, the depth used to be shallow. and because of that, sometimes it used to undercorrect. So many new knives have come, LRI knives, where the configuration of the knife is a rectangle to ensure the proper depth right from the beginning till the end. But with LRI, this is a child's play. Flax, this is a child's play. So LRI cuts before corneal or epithelial edema sets in. The reason why we do LRI at the end of cataract, not at the end of this cataract surgery, but at the beginning, is because by the end, corneal epithelial edema is there, cornea is swollen, and you will get superficial LRI. Over in flax, we are doing it even before taking a first incision. So the cornea is clear with, or epithelium is clear without any edema. So more accuracy. Because of that, of course, there are less chances of perforation, and perforation means in that particular case, astigmatic control is gone. Less chances of off-center placement. Now, many times when we do manually, the LRI can be off-center. And second thing is that, rather than an arc, it is, it is multiple small line segments. Okay. If a surgeon is not very comfortable. In this case, you get a perfect arc at all times, which is concentric to the corneal diameter. And it's it is very easy to open up. There are some people who keep it intrastromal, and at the end of 1 month, if there is a residual astigmatism, they can open it up on the slit lamp. That's very easy. Now let us take two examples. Number one is we implanted a toric EROV lens, 68-year-old male patient with a standard cataract and a cylinder of 2.14. So this is the calculation, 2.14 at 179, and this is was the plan where the placement would be at 1 degree and the incision would be at 150 degrees. This is the image before the docking. Now we have docked it. Now registration is complete. Just look at this cyclotorsion clockwise 2 degrees. So it measures cyclotorsion and ensures placement right on the right, exactly where you want. Then you go to the shifting of the incisions. You can see that the side port is being shifted precisely. Then the main incision. Now I'm sorry for that. Okay, see the way capsulotomy is happening, the nucleotomy is happening, the CCC is absolutely centric. Similarly, this box configuration tells us the same thing. And then we go to the surgery, very quick. You see how easy it is to open the incision now. Okay, it takes one stroke, and this is the VVT lens, VVT toric. I'm going under the IOL and proper placement. Under the IOL for removal of the visco. Patient was 66N6 on day 2. Then there is another patient where we had to do LRI. 59-year-old male with a standard cataract with a cylinder of 0.7, as we discussed. That now we are doing astigmatism, LRI only for cylinders between 0.7 to 1 or 0.625 to 1. And this was the plan of action. This is the femto LRI details. 25 degrees of arcs at centered at 24 degree, and astigmatism effect of 0.94 where the cylinder is 0.92, and 8 millimeter arcs with 85% depth. And this is the plan of action. You can see that these two LRI are there. And now we go to the, this is the pre-doc image, post-doc image. I will skip the registration. Now straight away go to the, okay, this is proper arrangement of the incisions. Now you can see on this OCT, I'm adjusting the anterior and posterior mark, corneal mark, so that I get proper LRI, and then start. Now you can see this configuration. These two tells us that CCC is bang in the center. Now over here you will get an LRI here and here as we had planned. That's it. And one more short video to show that opening of the LRI is very easy. Okay, just have to dip the femto spatula and move it to and fro, and that's it. Then this is the um, trifocal lens. Sorry. So post-op day 1 patient was 6'9" and N6. Thank you very much. Where is the thank you slide? Anyway, thank you very much.
Thank you, sir.